Hello, dear friends. How wonderful it is to be with you again. I hope you're all continuing to do well. I'm Mark Golub. This is our JBS series, Gam Yachad, Together During Covid-19. I hope many of you know the classic Jewish folk song, Hine ma tov u'manayim. How good and pleasant it is, Shevet Achim, for brethren to dwell, Gam Yachad, together. How wonderful it is to be able to be together during this coronavirus pandemic. I look forward so much to this time with you, virtually every day. And if you're alone, and it can be especially difficult to be alone, especially in frightening times like this. If you're alone, I hope you know I am with you. JBS is with you. All of us at JBS, we're all with you. You are not alone. And you know what I mean. We're not physically in your living room or your kitchen or your bedroom or your exercise room, wherever you watch JBS in your home. But emotionally, I am with you and I care about you. So many of you are in touch with me all the time. Lovely, lovely. You know, I try to explain what it is to receive an email from somebody who says lovely things about the work I'm doing personally, but more so about JBS. And it is not only affirming, it is energizing. And it gives me a sense of connection to you. Even as I look into this camera, I see all of you. I don't even know what you look like. I know your names. Sometimes many of you send me many emails. Some of you send me one. Doesn't matter. And by the way, every now and then, somebody sends me the nastiest email. It just always surprises me. What's the point? You know, all we're trying to do is provide you with quality Jewish programming, intelligent Jewish programming. And to be critical of, first of all, me, what's the point? Or JBS, you know what? Don't watch. You know, I say to myself, I speak to my wife, Ruth, why would somebody complain? Don't watch. And not everything on JBS is for everybody. You find what you like. You don't like my style? Don't watch me. So, but again, it's a teeny percentage of the emails I receive from you. Almost all of them are just so wonderful. So, I really care about you. I feel I know you. I love you. I care about you. And I hope this period of time is as easy on you as it can possibly be, that you follow the rules, you stay safe, and that you stay well. And don't count the days. Don't count. This will go on as long as it needs to. There are some signs that it won't go on as long as we once feared. There seems to be tests on the immediate horizon. They may not only show if someone is carrying the virus or not, but whether one has built up antibodies, which means that one is immune from the virus and may be permitted back into the workforce, which could slowly but surely restart this economy. And these tests are so simple. Nose swabs, even saliva tests, where one spits into a cup, hands the cup to a medical technician. Moments later, you know what the story is. And there's even talk of a vaccine. One Israeli company thinks it might have a vaccine that's proven effective and gets approval and is ready for public distribution in a matter of months. And we hope to have more information for you on that Israeli company and its potential vaccine next week. But in the meantime, it is what it is. So don't count the days. And it's hard enough to remember which day it is. So any of you who have that problem, knowing which day of the week it is, just go with the flow. But the days tend to smush together, don't they? My daughter-in-law, Lindsay, told me that there's a new expression for days of the week. Today is Blur's Day. Every day is another Blur's Day. That's how it feels, isn't it? It's so perfect. So that's where we are. And the best thing of all is we can be together, Gam Yachad, at this time here on JBS. By the way, I really would love to speak with those of you who'd like to speak with me, to talk about how you're doing, how you're feeling, for you to tell me what you like about JBS or which programming we might add during this pandemic to give you more hours of enjoyment. Or if you'd like to speak to me about something you've been wanting to ask me after listening to a Jewish 101 or a From the Aleph Bet or a L'chaim or on any Jewish matter at all, I love to have the chance to speak with you on JBS. So this is what we're proposing. If you would like to speak with me on JBS, on the air, by phone, email me your name, telephone number, and where you live, and a few words about what you'd like to talk to me about, and I will call you back during a Gam Yachad program. Unfortunately, we don't have multiple lines set up right now and a staff to take your phone calls. But we can call you. So if you'd like to speak with me on the air, please send me your name, your phone number, where you live, a few words about what you'd like to talk about, and send it to our JBS Community email address. That's jbscommunity@jbstv.org. And please remember, you can use that same email address to send me the name of anyone you'd like me to read as a mazel tov for a simcha, or as part of a Misha Berach list for anyone who's ill, whom you'd like mentioned, or any yortzeit name, the name of anyone who may have passed away in the last period of time. If you don't have a synagogue setting in which to have these names read, please know I'm privileged to read these names for you on JBS. Again, send your information to the same email address we've set up, jbscommunity@jbstv.org. And one more housekeeping matter before I introduce you to a fascinating individual who's on the medical front lines in fighting the coronavirus. As is true for virtually all of us, being self-quarantined has created all kinds of havoc and changes in our normal routine. And for JBS, it means we have moved our mailing address to our Stamford post office box. If you're a longtime viewer of JBS, you know our P.O. Box has always been Post Office Box 180, Riverdale Station in the Bronx. We've had that same P.O. Box since L'chaim first premiered on WMCA radio in 1979. Hard to believe it's that long ago, 1979. That's 41 years ago. But now, I need you to I need to ask you to make a special note of our new address in Stamford, Connecticut. Our address is now JBS, Post Office Box 360, Stamford, Connecticut 06904. So please make a note of our new address, especially for tax-deductible checks to help sustain JBS during these most difficult times. Our address now is JBS. It's also GEM, by the way, Jewish Education and Media. Either name works. JBS or GEM, Post Office Box 360, Stamford, Connecticut 06904. And even when you see a program on JBS that may have the old P.O. Box address in the Bronx, ignore it. Rather, please use our Stamford P.O. Box address. And if you are in a position to use some of your tzedakah dollars to help keep JBS on American television, my deepest thanks. Well, one of the things that's important to all of us is to speak with medical professionals about the coronavirus, to get an update on what we know and what we don't know, and to ask as many questions as possible. So I'm most pleased to have a conversation with Dr. Benjamin Kruskal, an infectious disease specialist who serves as the medical director of the New England Quality Care Alliance. And Dr. Kruskal is also the coronavirus liaison with the Tufts Medical Center in Boston. Here is my conversation with Dr. Benjamin Kruskal. Ben Kruskal, thank you so much for joining us here on JBS.
It's a pleasure.
Can you explain to our audience first exactly what you do in terms of your medical work?
So I do a variety of things. Right now, given what's going on with COVID-19, I'm actually co-incident commander for NEQA, which is the New England Quality Care Alliance, a network of 1,700 physicians affiliated with Tufts Medical Center. So what I do right now is coordinate the network response to COVID-19.
Okay. So in essence, Ben, you're part of the front line here. I guess, are you in the greater Boston area?
I am, yes.
Okay. Incidentally, the audience should know you're married to a rabbi, correct?
Correct.
Her name is?
Sue Frederick.
Okay. And how was your Pesach?
You know, it was a singular Pesach for sure.
Absolutely.
One night we did a Zoom Seder with friends and family. Another night we had just the four of us.
Okay. As she experiences the COVID crisis, does she have a congregation of her own?
No, she does spiritual direction and editing.
Okay. I assume, though, that she also is, like all of us, I don't know if it's true for you, but for many of us, we are confined to our homes. Is that true for your wife?
It is, and it's actually true for me as well. We do all of our work remotely. So I am constantly on Zoom and similar platforms talking to various colleagues.
Okay. So I only have a million questions. I know I don't have enough time to ask you all of them, but I want you to help us understand as much as you can. And I want you to understand the answer, I don't know, for me is an absolutely acceptable answer given the difficulty of this pandemic we're dealing with. So you'll tell me what you know and you tell me what you don't know. First of all,
absolutely.
Do you understand what we now believe is the way in which this virus, the coronavirus, is transmitted from one person to another? If we do know, can you explain it to us?
We know a fair amount. And this virus is behaving like many other respiratory viral infections. The principal mode of transmission is what's called in the field respiratory droplets. These are relatively large droplets of fluid containing virus that are expelled from the mouth and the nose only when we sneeze and cough, but also when we speak and laugh. That
By
is
the
the
way,
mechanism of transmission.
okay, Ben, that's not the way we were told. That's not what we were told in February and March. It sounds to me like this is something the scientific medical world has learned during the first part of April. Is that fair?
Actually, not quite. At the beginning of an outbreak, generally speaking, we assume the most different possible mechanisms of transmission for safety. And so at the beginning, we assume not only respiratory droplets, but what's also usually called airborne transmission in the common parlance, or droplet nuclei in the infectious disease lingo. So when we are dealing with a new infection, we assume that it's transmitted by both of those means, as well as by direct physical contact, because that's the safest way to proceed.
And then at what point, as you got more sophisticated in your understanding of this virus, what would you say now about the way it's transmitted? And the real issue for me, as I've been following it as best I can as a layperson, is to what extent is this airborne? And I know an airborne virus is a technical term within your medical world. But what we want to know is to what extent can somebody walking down the street or 10 feet away from an individual, more than the 6 feet we were originally told, to what extent is that virus expelled from a person who has it, not simply by a cough, not simply by a sneeze, but simply by breathing? And how long does this virus remain in the air as opposed to being droplets that fall to the ground? Because initially we were told if you stay 6 feet away from somebody, even if they cough, the droplets are going to fall to the ground. And if a droplet does not get on you, and now we're talking about your hands, and if that droplet on your hands never gets into your mouth, nose, or eyes, the respiratory system, as dangerous, as communicable as this virus is, a person who is disciplined is relatively safe. My question for you now is, has that proven less true, and are we in some way less safe than we thought we were if we follow the rules?
So none of these viruses is ever transmitted by a single mechanism 100%. So you have to take everything with that caveat. That being said, for this virus, it appears that the vast majority of transmission is through respiratory droplets. There may be small amounts of airborne transmission, probably under some very specific circumstances that produce fine particle aerosols. So these are things that we see in the medical setting very commonly. Various kinds of breathing treatments, the placement of a breathing tube, certain things generate those aerosols, but they're not things that happen commonly in our everyday life.
So again, one of the things that I'm interested most in, Ben, is trying to alleviate, honestly, whatever fear and anxiety people have. I don't want to alleviate anxiety by sugarcoating the reality. So I want to understand the reality as best I can. And Ben, on JBS, we have many, many viewers who are older. We have many viewers who are in the demographic that's most highly at risk. And we have many people who are living alone. And it's scary. And, on the one hand, when you hear there are, more than 10,000 infected people in the city of New York. When I say infected, they are in hospitals. More than 10,000. There is more than 8 million people in New York. That means more than 700 million people in New York, more than 800 million people in New York do not have the virus in any serious way. But the impression one gets when one watches CNN or when one picks up the newspaper is it's all around us. And it's seeping through the door, and it's flying through the window, and we are all at risk. And I want to know the extent to which people have, if they're careful and they follow the rules, are they relatively safe, or do you, Ben, worry for people just living in Boston and living just in New York and living in LA and living in Louisiana and living in Florida and living in Israel and living in Italy and living in Spain? To what extent is a professional worried about this just getting us, or to what extent is this a very serious disease, a very serious virus? It must be controlled. The best way to do it is through separation and following the rules. But if you do, you are relatively safe. What insight can you give us?
The answer is, if you follow the rules as we currently understand them, you are safe. I'm not worried about somebody opening their window and having it fly in from outside. What I am worried about is people who consciously or unconsciously are breaking the rules, often feeling like, oh, this isn't enough. This isn't enough to worry about. So it's the opening the door for somebody who's handing over a package, for example. Is
that dangerous in your mind?
It's not super likely to have transmission under a brief exposure like that. But if the person happens to be excreting a lot of virus, and some people do for reasons we don't understand, then it may be that there's a transmission that way.
So are you saying that in your home, you will not open the door to accept a package?
Nope. When people have stuff to bring us, they leave it outside our door. We wait till they're gone. We bring the package in. We wipe it off.
I understand. Would you ever go to a store and buy something you need?
Only if I couldn't find some other way of dealing with it. And I happen to be in a at-risk demographic myself. And so I am especially careful. But just as an example, I have 3 grown daughters who live within a couple of miles of me, and I did not see them on Pesach. I didn't have a Seder with them because I am worried for them and for me.
Yes, I understand. Would you ever take a drive in a car, drive back into your garage, close the door, and come back into your home? Is it dangerous to go out for a drive in a car?
It's not dangerous to go out for a drive. It's not dangerous to go out for a walk if you don't live in a densely populated area such that it's easy to avoid people. I happen to live in a suburb where I can go out for a walk and I see people coming. I cross the street. That's easy. That works. But if I lived in Manhattan, I'm not sure I would go out.
And what about would you go out for a drive, and then just pull into your garage, and return it to your home and wash your hands? Is there anything dangerous about that?
There's nothing dangerous about going out for a drive. Again, if I'm not opening the window and stopping to talk to somebody, if I'm not getting out and going into a store, those things increase danger considerably.
Okay. What about the evolution of what we've been told about wearing masks? For a long time, we were told, CDC, we were told not only you shouldn't wear a mask, it's counterproductive to wear a mask, it creates more of a problem. Recently, there seems to have been a 180. Can you describe what's happened? Why did that 180 occur? And where, Ben, do you come out now yourself?
So the answer is, when you look really rigorously, there is very little evidence on whether masks used by ordinary people have a role in protecting. And the literature on this is not voluminous at all. There's only a few studies that are helpful, and those few studies address some very specific circumstances which don't exactly apply to the kinds of circumstances that you're describing. So that's one piece. Is just the bottom line is we have little evidence. Second, we have still, although it's getting better, a scarcity of really effective masks. And those really effective masks need to be reserved for the people who are at the highest risk, who are the healthcare workers on the front line taking care of patients who have COVID-19.
Of course.
But even so, if we go back to the evidence, it's, as I said, scanty, but I'll just give you sort of two sides of the coin. On the one hand, you would say, even if it's not a very sturdy barrier, if it covers your mouth and your nose, it's going to reduce droplets that might come towards you and keep them from getting in there. And that is intuitively sensible. And it probably is, in fact, the case, although there's limited data to support it. It depends a lot on what the mask is made of and how it's made. But let's just take for the sake of argument that intuitive feeling that you know, it's covering your mouth and your nose. How can it be bad? So there is a way it can be bad, and in fact, this is a way that has been shown by evidence in some specific healthcare settings. When you're wearing a mask, you are often, again, consciously adjusting it. If the mask is filtering effectively, the outer surface of the mask gets contaminated with virus. And you touch that to adjust it, and then later you touch your face, boom, you're infected. It turns out that in some of the respiratory viral outbreaks, there's reasonable evidence to suggest that that was a primary mechanism for healthcare workers getting infected, people who wore masks assiduously, but still got sick.
Interesting.
So that is and again, we all do it unconsciously.
Yes.
Just like we touch our face unconsciously.
Yes.
If we're wearing a mask, we're fiddling with it.
Yes.
So it's not something about which I think we can say dogmatically, is it better or worse to wear a mask?
Okay.
I would probably, sorry?
Go ahead. Probably.
It is probably, I would say the balance between those two would shift somewhat if we had really good masks. So for example, if we had medical masks freely available to everybody, they're so much more effective than the cloth masks that people are making, that I think the balance would shift towards feeling more value in wearing a mask.
Okay.
As it is, the fabric masks which people are making, which are very reasonable, are, you know, just not nearly as effective.
When you and your wife talk about the entire pandemic experience, are you ever annoyed that there was one presentation of the mask issue early on and there seems to be a different one now? Does that bother you at all, or not really?
It doesn't, because I live through the evolution of our knowledge in that same way as everybody does. I understand some of the subtleties. For example, the advice about avoiding potential airborne stuff that happens early in an outbreak and that may later change. I understand that very thoroughly because I'm part of it. But in terms of the evolving advice about whether ordinary people should wear a mask when they go out of the house, it really is so unclear. There's really so much evidence on either side of that I am not at all annoyed we're all kind of struggling with trying to figure out where the balance lies.
I understand. Are well said. So one of once you get past what must I do to be safe, and you've helped define that, you've basically affirmed the things we have learned. And what I did hear you say is, while many people break the rules, bend the rules, cheat one way or another, and when they do so, they're more at risk. For those who are sort of compulsive, obsessive fanatics, the chances of their getting this disease, nothing's zero in life, but it's very, very small. And I'll say it again. If 10,000 people have the virus in New York, more than 8 million don't. And the question is, how do you view it? And although it seems like everybody has it, 8 million don't. Now,
Except,
go ahead.
and you may be getting to this yourself, but one of the big unknowns about this infection is how many people have it without symptoms. And
Yes,
I read a wonderful...
Yes, although what I'm referring to is 10,000 people have it with serious symptoms.
Exactly.
Okay.
So 10,000 people have it with serious symptoms, and those people are undoubtedly transmitting it in a huge way, but there are people with mild symptoms who are transmitting it, probably not quite as much, and there are undoubtedly some people with no symptoms who transmit, and we just don't know how many of them there are.
Yes. Okay.
And I read a wonderful analysis of this yesterday by an epidemiologist colleague who said, she described the sort of two extremes as the big denominator. That is, there's lots of people out there who have no symptoms who are transmitting, or the cases are the cases, meaning the ones we know about probably represent most, if not all, of the cases that are out there.
And what's your instinct, Ben?
My instinct is that there's a big denominator. My instinct is that there are a lot of people who are asymptomatic who are transmitting, and knowing where we are between those, undoubtedly those are extremes. Undoubtedly we are someplace in the middle, but knowing which side we're closer to, that's very, very important, and we don't have that data yet.
Yes. In that regard, by the way, there seems to have been efforts lately to downplay. It's not the right word. Not downplay. To revise the number of people expected to get this seriously and to die. And some of these studies are being done at the University of Washington. Out of Stanford, there were three doctors, one of whom was a Jew, who said that the numbers initially were way overblown because we were not understanding what the denominator really was. And that brings me to the next question for you, because once we get past the issue, what do we do to keep safe? The question is, how long is this likely to go on? How long will America have to be shut down economically, which has terrible consequences for real human beings? It's not a theory. If people are out of work for a long time and they have no income, either to sustain a business or to sustain a family, it is horrible for them. And their lives are at risk from that as well. And then the question is, at what point do we have either medicines or a vaccine which will protect the population as a whole and allow us to resume, it may be a new form of normal, but some form of normalcy? What's your sense now? And I know this is something you think about all the time. What do you believe we're looking at in terms of time frame?
It's a very tough question. And the bottom line is we don't yet have enough information to make a really good guess. Among other things, that the size of that big denominator, the number of people who are infected and showing no symptoms really matters, because the more people who get it and then get over it, the more people who can't transmit it to other people. In other words, if you get it and get over it, the assumption is that you can't get it again and transmit it to anybody else.
Okay, although
that is the way.
That's a very important word you just used. It's an assumption. We don't really
Correct.
know, do we, Ben?
We don't have the data yet. By analogy with many similar viruses, we think that that's very likely, but it is not proven. And that is, again, a piece of information that people are eagerly seeking.
Yes.
That people are doing studies about in China, in Italy, in Iran, here, but we don't really have good data yet.
Okay. Nor do we know, as I understand it, whether if someone has antibodies because they've had it, how long those antibodies last inside a body, in a person, and whether a season later they're still vulnerable or a year later they're vulnerable, because we do know that in other viruses, one does need a vaccine every year because the antibodies change and the virus morphs, so that there's a lot here we don't know in terms of whether a person can get it a second time, correct?
That's correct. And again, if you asked me to put a bet on it, I would bet that it will confer lasting immunity, because there are so many other respiratory viruses that behave the same way, but there are some that don't. And so I wouldn't bet the house on it.
Okay, but by the way, it is comforting to hear, again, your instinct, and we will hold you to nothing. You're not a prophet. You can't prognosticate the future. So understand, I hear you. Your instinct is it will be, you get your antibodies, you're safe from it from then on, but you're acknowledging we don't know. Okay, and let's talk about medicine and vaccine. There's everywhere in the news, there's this hydroxychloroquine, and given with certain antibiotics, there are doctors who swear, there are patients who swear it is to some degree efficacious, especially if it's given early enough in the process. And then there are others who are just saying there's no test that's ever been done of a reliable nature, there's been no blind study, and therefore it's irresponsible to even mention that. At the same time, the FDA is now approving trials. There are trials going on throughout the world, including in Israel. What's your sense of that particular drug?
So I believe at the literature on hydroxychloroquine, and are responsible to use that drug clinically outside of a clinical trial. I understand people want hope, and I am not trying to shatter anyone's hope, but this is a drug, like most drugs, that has actual side effects. It's not perfectly safe. It's safe enough that we use it clinically for other conditions like lupus, but it is not perfectly safe. It has some significant side effects. And
what are they? So
the two of most concern are that it can cause cardiac arrhythmias, in particular in combination with certain other medications, that is particularly concerning. The other is it can cause damage to the retina of the eye.
Okay, I appreciate what you've just said. Here's my problem. I'm seeing people who get the disease, relatively mild symptoms. I know people they're younger, they experience it for a certain period of time. It's not pleasant, but it's not terrible either. And then they're better, and now they have the antibodies. And then I hear about people, some of whom I know, who end up in the hospital and ultimately go on a respirator. And again, I don't want to scare anybody, but what I understand is, and I want you, Ben, as a doctor to confirm or not, if somebody goes on a respirator, there is a greater than 50% chance that person will never live, that person will die on the respirator, will never come off the respirator and have a life. if somebody said to me, Mark, you may end up with arrhythmias, you may end up with retina problems, or you may end up dead. It wouldn't take me a moment to say, I want to try a drug which some people have found to be efficacious, which may have side effects, but the downside is so minimus compared to my losing my life. I don't understand why every doctor isn't saying we should do tests, use it very cautiously, but if you want to try it, it is absolutely an option that should be on the table for you.
What really we're talking about, Mark, is the balance between the probability of harm from the drug and the probability of benefit.
Yes.
The probability of benefit is really not known in any way. The published data are done under sufficiently uncontrolled and chaotic circumstances that I would not say they demonstrate anything at all. So we have drugs that we know have certain risks. We have no idea whether they have benefit or not. We know that there are theoretical reasons that they might confer benefit. But when you give it to a few patients and some of them get better, you don't know if they were going to get better anyway. This is the problem. So
Right.
This is what medical ethicists call equipoise. The known risks and benefits are sufficiently uncertain that the scale is balanced. And that is exactly the circumstance where clinical trials should be happening.
Okay, you say it very, very well. And what's your sense about a vaccine? Do you see it on the horizon? There's some news coming out of Israel. I have not yet been able to confirm it myself. I'm trying to talk to the company. They haven't been willing to talk to me yet, which always makes me uncomfortable. And then, we hear people like Dr. Emanuel saying it's going to take 1.5 years before there's a vaccine. And until then, all of us are going to have to stay inside, and the economy is just going to implode. What's your sense?
So I'm going to leave the predictions about what's going to happen in terms of social distancing to one side for the moment and just talk about vaccine. I have no doubt that we will get a vaccine that is ultimately successful. The question is really how soon will we have it? And this is a place where, again, caution is so important. You would say, how can it hurt? We should just get the vaccine as fast as we can and give it to everybody. But in fact, it can hurt. And there are examples of vaccines that were made against viruses that were given in an era when people weren't so careful and caused many people severe harm or even death. And there are mechanisms we can understand by which that might happen. And so the clinical trials of a vaccine have to be approached with great care.
I understand, and again, you say it perfectly, and you and I agree we would like this to happen as soon as possible, but we want it to be a safe vaccine, and we also want it to be an effective vaccine that does in fact protect us when we go back into the world. I am not going to ask you the economic issue. That's not your expertise. But I do want to ask you about people who are in your profession. And in the Jewish tradition, there is the highest regard for those who are doing medicine. And as far as I'm concerned, and I say this every high holidays, they are doing God's work. And in the Jewish world, you're not permitted to rely on prayer for cures. You can pray, but somebody who prays and doesn't take medicine, somebody who prays and doesn't go to the doctor, somebody who prays and doesn't take care of themselves physically is violating Jewish law. So for me, the work you're doing is of the highest quality and spiritual service that any person can do. It's not being a rabbi or a clergyman. It's doing what you do. It's what you do, Ben. And I want to know now how you feel about your colleagues. Your colleagues who are not at home, but they're in hospitals and they're in other homes where they're dealing with very ill patients. A great many of your colleagues end up with the virus themselves. So I'm asking you to talk about the people you know, how you feel about them, what you feel they're doing, and the extent to which they have enough of what they need to keep themselves safe. Just talk for a moment about, again, your medical world.
So this is an unusual situation for me, not because it's a pandemic. It's about the third or fourth major infectious disease outbreak that I worked on, but it's the first time when I'm not seeing patients myself. And I feel guilty about that. And there are reasons why I'm not doing it, but nonetheless, I wish I were there in some ways on the front line, even though I'd be scared to be. My colleagues who are doing that frontline work are, like the firefighters on 9/11. They're like the police officers who go out every day and risk their lives. I have tremendous gratitude and admiration for them. I want to make sure that we do everything possible to protect them. And news is that if you do the procedures correctly, if you have the right equipment and you use it correctly, the risk is actually very, very low. And in fact, at the hospital where I am most connected, the employees who have gotten sick have virtually all gotten it outside of work.
That's wonderful. It's wonderful that they are not getting it in the hospital, correct?
Exactly.
Yes. What I'm about to say is a little bit chutzpahdik. I am not your wife. I don't know that your wife can say to you what I'm going to say to you. But I am a rabbi. And I'm saying to you, you don't need to feel guilty. You are doing what you can in your way at the same time that you protect yourself. And you said to us already, you are in a higher risk category. You have a responsibility to yourself, to your wife, your family, to your daughters or children. I don't remember what you said to me. You had 2 children who couldn't be with you for Passover. Did I hear you say that?
A total of 5. 3 of them are grown and out of the house.
Good for you. Anyway, you have a responsibility to them. And what you're doing is what you can do in a most responsible and divine way. And it's been wonderful meeting you. I'm sorry we had to meet this way. I really hope when this is over, whenever that will be, Ben, I get a chance to meet you and your wife and to really shake your hand, if not give you a hug. And it's been very kind of you to let me ask you question after question and for you to give us such thoughtful answers. And people should know this was not easy for you. You have a very, very busy schedule. We've tried to schedule this a number of times. You went out of your way to make sure you and I could speak. I am grateful personally, and I'm grateful for the JBS audience. I hope, however, at some point, you'll let me continue this conversation if there's reason to do so. In the meantime, kol tu b'hatzlacha, you stay safe, you stay healthy, and we will talk again soon.
Thank you very much, Mark. And I will say what my grandparents would have said, sei gesund to you.
Du echt, my friend. We'll talk again. Thank you. My best to your wife as well. Thank you. Bye-bye.
Thank you very much. Bye-bye.
Dr. Benjamin Kruskal, Medical Director of the New England Quality Care Alliance and the Coronavirus Liaison with Tufts Medical Center in Boston. And a most thoughtful and lovely physician. I'm most appreciative of his finding time to speak with us here on JBS. So, my friends, here are the rough coronavirus numbers as of today, April 15th. In the U.S., there are still over 600,000 known cases of the coronavirus. but the rate of recovery in the United States has increased 1.5 points to 7.5%. And the number of deaths in the United States holds steady at 4% of those known to have the virus. In Israel, as of the more than 12,000 known cases, the percentage of those recovering went up 2.5% to 20.5%, while the percentage of deaths held steady at 1%. So things may actually be slowing down. And one more time, I want to remind you that if you're unable to celebrate a simcha in a synagogue setting, a birthday, anniversary, accomplishment, or if there's someone who's ill, whose name you'd like to include in a Misha Berach list, or if there's someone who's passed away you'd like mentioned, please email the information to jbscommunity@jbstv.org. And so until the next time, I'm Mark Golub. Stay safe and be well, my friends.